Great, Gary, Kuila, thank you very much. Are we all set over there? All right. Great group of individuals, and it's always just a lot of fun and really special to recognize those amongst us who do such a terrific job, and it just makes me proud to be a part of the movement. Talking about pride and honor, what an honor it is to have with us today one of the men who started it all, Dr. H. Jack Geiger. What a fantastic and well-deserved welcoming. Thank you all very much for that. We honor Jack as the father of the community-based health center model in the United States. He co-founded and directed the first rural and urban health centers in Mound Bayou, Mississippi, and Columbia Point, Boston. He inspired the growth of the Community Health Center program, which, as we heard yesterday, now serves over 22 million people in 9,000 medically underserved communities. Dr. Geiger's life is a testament to his dedication to improve the lives of people suffering from poor health, poverty, and discrimination. And it's so special to have him with us today as we commemorate the March on Washington 50 years ago. Absolutely. As we continue the long struggle in this nation for social and economic justice and civil rights, hopefully, finally, ultimately, truly giving meaning to the words equality, opportunity, and justice for all. Many don't know, but I would assume in this room, many probably do, that early in his career, Dr. Geiger courageously bucked the establishment, promoting and leading campaigns to end discrimination in hospital care and medical school admissions. That effort extended into the civil rights movement of the 1960s, when as part of the Medical Committee for Human Rights, he organized medical students to provide care for civil rights workers, protesting discrimination in the South. And as Dr. Geiger often likes to tell the story, those students and medical residents who were mostly from the North were really in for the shock of their lives, seeing firsthand for the first time the poverty that existed in the South and the people's dire need for health care and doctors. Dr. Geiger is a founding member and past president of the Physician for Human Rights, which, oh, by the way, is a group that won the 1998 Nobel Peace Prize. And he's also a founding member and past president of Physicians for Social Responsibility. He has used scientific knowledge and collective voice to raise awareness of issues and concerns impacting health on a global scale. He's lectured and authored extensive writings on the medical and biological effects of nuclear weapons. In his work, he's also brought to light other human rights abuses, leading missions into Bosnia, Iraq and Kurdistan, the West Bank and Gaza Strip, Central America, and other troubled parts of the world. Dr. Geiger has merited honor for his selfless dedication to his profession and his advocacy for minority populations and the medically underserved. Yet what we know that stands as his proudest honor and what will ultimately be his legacy is the Community Health Center program, which has now grown and flourished over 50 years and today is leading this nation to better health care for all. Absolutely. Dr. Geiger is the Arthur C. Logan Professor Emeritus of Community Medicine at the City University of New York Medical School. And now let's join and welcome our great leader, founder, and beloved friend, Dr. H. Jack Geiger. I'll get this down for you, but thank you. Before we get started, Dr. Grace Wong would like to present you with a lei, so you'll have a flower necklace before you start your.
Right there we go. Thank you.
Thanks.
Okay.
All right, you all set?
Yeah. Oh, good. Thanks. I've got, can we bring up the first slide? Is there a slide thing and a screen? There we go. The other one, there's two pictures. We'll start with that one, and then I promise you there's only going to be one more. And before we get to that, I want to thank you for the chance to be back here. This is my extended family. And the first thing I need to say is I got some notes here, but I'm probably not really going to be able to read them. I'm the living proof, I hope, that you can lose most of your eyesight, but still hang on to your vision, which is what all you folks are doing. And I need to begin, after all of those flattering words, by pointing out that we all stand on the shoulders of other folks and the work that they have done. And I know many of you know at least some of the story, but I want to spend 2 minutes or so talking about our origins and how fortunate we were that a bunch of things came together all at the same time and got us going. Let me begin with these two charts of where we are now. These are a couple of years old. They were put together by the staff of the New England Journal of Medicine to accompany an article on community health centers in the New England Journal that a couple of us co-authored a few years ago. And that first chart is a representation of the percentage of the population in each state of the United States that are cared for by community health centers. At the top of the list, if I remember, is West Virginia, where we take care of 43% of all of the people in West Virginia, and that's probably risen. And the numbers vary in other states, but I think the overall average is close to 20% if we look at the country as a whole. That's extraordinary, and that's something that I think a lot of people still fail to fully understand and appreciate. The second slide, the second map, that's a chart of the United States with one dot for every one of the then 8,000, now outside 9,000 sites of delivery at which community health centers are providing primary care to patients. 9,000 now. It's my favorite map. It looks like a map of the United States with measles. But it is a record of what has happened so phenomenally over these last 40 plus years, thanks to you and your predecessors, and a lot of struggle and a lot of leadership from NACHC. That's where we are. Let me spend just a couple of minutes on how it began. And it really began, of all places, in apartheid South Africa, where a group of young physicians, Sidney and Emily Clark and their colleagues, who are anti-apartheid resistors and cared about the health of the African population and the Indian population and even some poor whites who were actually the people producing the wealth of the country. And in a rare window of opportunity in the early 1940s, started the first modern community health center and the discipline that came to be elaborated as community-oriented primary care, that said a health facility has a responsibility not only for the clinical care of every individual patient, but for the health of the whole defined population or defined area that facility serves, community-oriented primary care. And that took off. It found its root in the first medical school in South Africa that was open to non-whites, the University of Natal Medical School in Durban. And I it was heavily funded, not just by the then government, but by the Rockefeller Foundation. And I was very lucky that the Rockefeller Foundation, at the end of my third year of medical school, the beginning of the fourth, sent me there for 5 months on a scholarship to work, study with the Karks and work in in Palella, the flagship rural, and one of the urban health centers. And I came back and finished and thought I was going to train for international health. And I had been in civil rights since 1942, when Bayard Rustin, Philip Randolph's deputy, recruited me to try and help organize. I was a student in Wisconsin for the first threatened march on Washington. Not a lot of people know that the one we celebrated again yesterday was actually the third. The first one was a threatened march on Washington to protest racial discrimination in defense plants, which all of them were doing right in the start of World War II. And that very threat was so great that Franklin Delano Roosevelt instantly signed an executive order banning racial discrimination in defense plants. And then a long bit later, I was an organizer for the second threatened march on Washington, mostly by the Congress of Racial Equality, protesting racial segregation in the armed forces. And that threat was so great that Harry Truman immediately signed an executive order desegregating the armed forces for the first time. And the third one was when we all finally got it done. But demonstrations, the way community health centers are demonstrations that struggle can pay off and make a real difference, not just symbolically for the nation, but in the lives of people. And at the end of my own training, that brought me to Mississippi with the Medical Committee for Human Rights, the medical arm of Freedom Summer, and the voting rights struggles in Mississippi that year. And doctors and dentists and psychologists and medical students and nurses and nursing students came down to Mississippi to provide that kind of presence and help and take part in all of the activities of Freedom Summer. And as you've been told, got a long look around. And at a kind of follow-up meeting in Mississippi that December, I finally unblocked and remembered Palella and started talking about community health centers and said, that's what we got to do here. And a whole bunch of people joined in formulating it. Well, it was just a pipe dream, but in January, helped by my colleague Count Gibson, who said, we don't have any money, but if you can find the money, we'll sponsor it at Tufts Medical School. I went to Washington, and the first person, nobody in the United States knew anything about community health centers. Nobody had heard of them in terms of official Washington. And I can illustrate that by saying I first went to speak to some high official at HEW and say, this is a community health center, and this is what it means, and it's part of community participation, and it's going to do it with people, not just for people. It's not going to look at all like an outpatient department, and we're going to put it all in one roof. And I got about that far, and he picked up the phone, and he called Lee Shore over at OEO, who just started there, this brand new federal agency. He picked up the phone. He said, I got a crazy man in my office, so I'm going to send him over to you because I don't understand anything that he's talking about. And very fortunately, so we had South Africa, we had the civil rights movement, and very fortunately there was this new federal agency that had the war on poverty, that had some commitment to experiment, to a community action program, to the idea that you did things with people, not just for people. There was this novel idea floating around of maximum feasible participation. And I went and talked to their head of research and development, one of the unsung heroes of our movement, Sanford Kravitz, who ended up funding Columbia Point Mound Bayou, Denver, Watts, Miles Square in Chicago, and Martin Luther King in the South Bronx. All of that first cohort without the slightest legal authority for doing so, because OEO had no mandate for health care. And I got to tell you, in our own case, so they did it under the rubric of these, well, these are all research and demonstration projects, and they're just experiments, but they got done. And in our own case, for Mississippi and Columbia Point, we had a short gestation, but a difficult birth. Sergeant Shriver, the head of OEO, was so nervous about, number one, getting into health care, and number two, doing it in Mississippi, for God's sake, that he waffled and postponed, and yeah, approved Columbia Point, that was easy, but kept stalling about Mississippi, appointed special committees, and finally, I took the dean of Tufts Medical School and went down to Washington on a day that I knew Mr. Shriver was testifying on the Hill and would be out of his office, and we staged a sit-in in his office. It's the only time in the entire 1960s that the dean was sitting in, not the students. And Shriver either had to get to use his office again or give us the grant, so he gave us the grant. But it was another demonstration of the kinds of struggles that all of the early community health centers, one way or another, had to face. And then, in the summer of 1966, Ted Kennedy came to Columbia Point, understood what health centers were, went back to Washington, drafted the legislation that created an Office of Health Affairs within OEO. We were legitimate at last, and the first $50 million for more health centers, and it just took off from there, and that's where 40-some, close to 50 years later, it has ended. Well, that's just the beginning, and that's just our first soon-to-be 50 years. Let me talk a little bit about where we're headed, particularly about community-oriented primary care. This sense that most of the earlier community health centers had in Lee County, Arkansas, and Beaufort Jasper, South Carolina, and some of the urban health centers, all of us not only did the things we needed to do to take care of our patients one by one, but to assess the status of health of the population we served and to figure out ways to intervene in the environmental and social other factors that were making them sick in the first place. And as many of you know, that got cut back sharply in another time of struggle in the Reagan years, when the proposal was, if they couldn't get rid of us completely, this is the administration and the Congress, to block grant us and kill us off that way. And we fought that off, but part of the price was that we got increasingly restricted just to the delivery of personal medical services, and much less for a while on the kinds of population interventions and public health interventions and marriage of personal medical care, primary care, and public health that we needed to do. And we are starting to recover all of that other focus, that other responsibility now, I think. And that's what really lies ahead of us. We can't do it alone the way those early health centers did in Mississippi. We are going to need allies and supporters in other organizations and other disciplines, and that's already happening. As you know, many of you, we have Health Leads, the student organization that finds resources for our patients and some of the social determinant problems that they face. As many of you also know, we now have medical legal partnerships in which pro bono lawyers are embedded in community health centers and hospitals. and find solutions for problems that very often the clinical staff has either been unaware of or too busy clinically to deal with, that there's going to be a threatened eviction for one of our patient families, or they're about to cut off the utilities and their disabled child in the home. And what neither the family nor the clinical staff at the health center knew was that if there's a disabled child in the home, it's against the law to cut off the utilities. The lawyer knew, and it got fixed. All kinds of problems of that kind. And there's very good evidence that the presence of a lawyer doing that changes the perceptions and scope of inquiry of the clinical staff itself. And there is a whole screening tool now in many health centers for those kinds of problems that provide a kind of larger version of where does it hurt than that they had before. Medical legal partnerships made the mistake of appointing me to their board not long ago. And I have been hollering at them since, and I hope this starts to happen, to say, look, what you're doing and what Health Begins doing is really valuable, but it's palliative, not structural. That doesn't diminish it. It solves problems that are real, but it doesn't change the social determinants that you're struggling with. And one of the things I would like to see is that lawyer at every community health center and community hospital in which they're embedded, and I hope that continues to grow, they're taking off, that they will become the agent that goes to all the other agencies in town, the Transportation Authority, the Public Health Authority, the Hospital Authority, the Housing Authority, and says, what kinds of projects can we collaborate on and do jointly with the health center that will start to work on some of the barriers that our own neediest population face and that are helping to make them sick. And we will once again become the instruments of social change as well as the instruments of healthcare that we were originally envisioned to be. That would be a glorious thing to be doing over the next 50 years. Let me close just by saying for a moment how much good I think you all do that we are often not aware of. And one of that kinds of good is the impact we have not only on the patients and families that come to our health center and see us all doing our work and see our diversity, both of discipline and race and ethnicity and language working together, and the children that come and see us. But in particular, the impact we have on those people of the local community whom we recruit and train and make part of our team, the impact we have on them and on their children, because that effect is what the cardiologists call antegrade, forward flowing. Look at what happens to their kids and grandkids, at least in part, as a consequence of their association with us. And how I learned about this, I'm going to tell you about two women briefly. How I learned about this was in the late 1980s. I was part of an organization that was the big support organization for the health sector of the anti-apartheid resistance in South Africa. Then at the peak of those struggles, an organization in New York and the US called CHCs, Committee for Health in South Africa. It's the Zulu word for heart. And we had a workshop every couple of years, a meeting at which all of the American National Congress people in exile came to New York to help people. And sometimes somebody from South Africa that could get out briefly. And we all networked and got up to date. And then we were careful after that meeting to send all of those exile leaders out to the medical schools in New York to give a seminar and spread the political word about the struggle. And this lady came to City College, where our medical school was in central Harlem. And she was a full-fledged physician. She had started her medical school in South Africa and had to flee because the police were after her for her political activities. Fled to England like so many others. Finished her medical degree, got advanced training in pediatrics, got an advanced degree in public health, highly accomplished lady, and gave her talk. And we were walking across the street to have lunch afterwards, and idly I said, "Where'd you grow up in South Africa?" And she said, "Phalela." And I said, "How old were you in 1957? She was 9. It turned out she did indeed remember this weird white foreign couple that she saw at the health center. That gave me a chance to ask a question. There had been a report after the full-fledged apartheid regime had shut down all of those health centers. There were 75 community health centers in South Africa when Verwoerd moved in and closed it all down, and the Karks fled to Israel and started again, and started an international workshop whose consequences you're going to hear about, the International Federation for Community Health, you'll hear about a little bit later. And the report was that somebody went back 10 years later and took a look and see if there was any difference between the population, the African population in Phalela, and one nearby that was just the same but hadn't had a health center. And the one difference they saw, it was said, was that there was a much higher level of educational aspiration and educational achievement in the Phalela population. And here she was in front of me, so I asked her if she thought the health center had anything to do with her subsequent trajectory, first as a lab technician, then as a medical student, then as this highly trained doctor, then as a political leader of the ANC in the United Kingdom. And she said, "Of course. You went to this tribal reserve, as it was then called, 500 square miles of misery, riddled with tuberculosis, malnutrition, syphilis, every infectious disease at the beginning, and totally transformed by the Phalela Health Center and COPC and the Karks." She said, "Of course. You went to the health center. You saw black medical students. You saw black nurses. You saw black and white people working together. You saw the people from our community that they trained who came out as health educators and data takers and all of the rest. And you knew that something was possible." Of course. Then she thought a little bit. And she said, "Well, I think to have that effect, you really had to live on the tribal reserve pretty close to the health center so that you were there often and got to know some of the people, and really you didn't just make a once-a-year routine kind of contact." And that makes sense. And then she thought a little more, and she said one more thing. "I think you also had to live in the part of the tribal reserve that was near the highway." And I said, "That doesn't make any sense. Why was that?" And she said, "Because you really had to understand that there was a road out of this place." And I realized at that moment, that's what we do. We build a road out for people in need, for people in poverty, for people who, because of poverty and racism and other barriers, may have constrained and limited aspirations, that we help to unlock, as long as, at the same time as we are doing the things we need to do about their illness and their health. And we need to understand that that's part of what we do. The second person who taught me this was a child of the Mississippi Delta, Elsie Dorsey, Lula Clara Dorsey, who grew up a black child in the Delta on a cotton plantation, had her first job at age 8 carrying water to the cotton choppers in the field, mostly women, for $1.25 a day. Lived in poverty, wore dresses made by her mother out of flour sacks, like many of the other kids in her community, and had a mind that I think was unparalleled among any of the many people I've known over these years. Went to school, learned her first literacy from her mother reading. They didn't have books in the house, but the mother read to them every night from the Chicago Defender and the Pittsburgh Courier, the other national black newspapers, every night about what was happening. Went to school, left school at the beginning of high school to go to work for Fannie Lou Hamer as a chief aide right at the very beginning of the civil rights movement. Married at 17 to another sharecropper, had 6 kids over those next years, lived in poverty and near poverty, did the civil rights work and the organizing work. When Head Start came to work for Head Start, and then at age 26 in 1966, came to work for us at the Delta Health Center in Mount Bayou as a trainer of nurse aides, and did her GED, her high school equivalency, at a program that we had for that purpose at the health center, taught by the staff, and became the deputy director of the farm co-op, the 1,000-family, 500-acre vegetable farm belonging to the people of the North Bolivar County communities that we had organized that ended malnutrition and produced thousands of tons of vegetables, not cotton, over the next years, ran it, expanded it. When the project all moved to SUNY Stony Brook outside New York, the Health Council had negotiated how many scholarships Stony Brook would provide, and they gave one of them to the local community. They gave one of them to Elsie Dorsey, and she was admitted without college. She just skipped it. She had her GED to the Graduate School of Social Work and graduated with honors, first in her class, and came back to Mississippi, worked as a social worker for the Delta Ministry, mostly in the Parchment Prison Project, dealing with men on death row and women in prison, and launched all of those 6 kids in college or on the path to college. And then when that was in place, went to Washington, working at night somehow to support herself, and did a doctorate in social work at Howard University. And then she went to Johns Hopkins and did a certificate in healthcare management program. And then she came back to Mississippi, and the board, in its wisdom, chose her to take my old job as executive director of the Delta Health Center. I have to add, for those in the audience that may have known her and don't know, Elsie Dorsey died last week at 73, unexpectedly and suddenly in her sleep. And I don't know how any of us who knew her are going to be able to manage that loss. But she is an exemplar of the kind of change in people, not just their health, but in their worldview and their vision of the good we do. I forgot to tell you about that first lady from South Africa. Her name is Nkosazana Zuma, and she was Nelson Mandela's first national minister of health when liberation came to South Africa. And the Palella Health Center had something to do with that. So out there in this decade and beyond to come, there are a lot of Dr. Zumas and a lot of Dr. Dorseys in potential out there. We are going to double what's on that map. We are going to keep going, and you are the guys that are going to make the change that all of this accomplishes. And I congratulate you in advance for what you're going to do. Thank you.